I now recognize Mr. Smith from Nebraska.
Thank you, Mr. Secretary, Mr. Chairman as well. Thank you, Mr. Secretary, for joining us today. I would like to start by calling your attention to a letter I sent to you on March 10th, a February 25th, 2023 article in the New York Times and a subsequent report by the Washington Post that have raised serious concerns about the Office of Refugee Resettlement at HHS. Everything about this situation, from unaccompanied children at the border to the lack of sponsor vetting to the ORR losing track of these children, I have to say is troubling. So I hope you will respond to my letter, hopefully by April 15th as requested, so we can ensure that HHS is able to address these issues. The COVID public health emergency is scheduled to expire on May 11th. I welcome this expiration. There are hundreds, though, of waivers, many of which have vastly benefited patients around the country, which immediately sunset with the PHE. These expirations have the potential to impact virtually every medical provider and patient, but would have a disproportionate impact, I believe, on rural and underserved areas like my home district in Nebraska. For example, it appears that without intervention, the following regulations will return to full force on May the 12th. The 96-hour and off-site provider telehealth conditions of participation for critical access hospitals, the 3-day hospital stay rule for skilled nursing facility admittance, and the long-term care hospital waiver of site neutrality in IPPS. Mr. Secretary, should we have the concern that the return to full enforcement of these regulations will have impact on patient access to care?
Congressman, absolutely. And we thank you for the extension to some of those telehealth opportunities that will expire at the end of 2024, but we need to do something permanently.
Okay, so I guess can we count on your support of efforts to make many of these provisions permanent that have proven to be effective, and especially for patients themselves?
We'll be there side by side with you as you try to negotiate the terms of that, because, again, most of this is baked in statute, and so we're going to have to make changes through Congress.
Okay, thank you. I appreciate that. Now, finally, earlier this year, CMMI released 3 new models targeting prescription drugs, and to date, CMMI tested more than 50 models, only 6 of which have delivered statistically significant savings, a less than 12% success rate. Not acceptable in many eyes. I've been concerned for years that CMMI often overextends itself by attempting to do too many things at once. And this leads to overlapping and counterproductive results which can harm both patients and providers, while currently wasting Medicare's finite resources. CMMI Director Fowler even said, quote, "We need to move away from this spaghetti against the wall, see what flowers bloom approach," end quote. Can you perhaps explain how simultaneously launching 3 different models targeting the same problem is different than the failed scattershot approach of the past?
And Congressman, I answer this knowing that as a former member, I, like you and many others, would always ask CMMI to test certain things. CMMI is supposed to be our incubator, our place to test ideas, but on a very small scale. So if they don't work, we've not spent a ton of money. But if they do work, the return will be phenomenal. And what we want is to promote innovation. So CMMI is the place where we can tell the private sector, give us your best idea. We'll help seed it, and if it can go, great. And if it doesn't, no one, including the taxpayer, loses a whole lot. So I would want to work with you to make sure that we get good ideas coming forward to CMMI, but I would hate to do anything that stifles the innovation and competitiveness that CMMI promotes.
Thank you. I yield back.
Mr. Thompson from California.